them?
Mm-hmm.
No.
Yeah? If you don't, you need to try to get one, even if it's just one friend, somebody you can go to and talk to. Okay. Turn to page 4. Types of crises.
On the PowerPoint. Slide 4.
Slide 4. Types of crises. Maturational, situational, and adventitious. Yes, ma'am.
Do you want me to log in on our Blackboard so you could at least pull up the student version that is uploaded to our Blackboard?
No. Thanks for asking, though. I appreciate it. Do you guys want me to put the student version on Blackboard? Does that help you?
That's fine.
I got it right here.
Yeah, we'll have it all.
Okay. I'm just feeling real lazy today. You know, it's coming down to the end of the semester, and I just want to get a little. Is that how you guys feel?
Yeah.
Okay. So there are 3 types of crises. You need to know these 3 types of crises, and you need to be able to recognize examples of them. All right? A maturational crisis. That means that you're growing up and changes are taking place in your life. As you guys find yourselves getting older, do you find you cope differently than you did when you were younger?
Yeah.
That's just part of growing up. Okay. Some examples of a maturational crisis are when you leave home for the first time, when you get married.
I mean, you said leaving home for the first time.
Yeah.
Is there 2 times?
Oh, yeah. Because, you know, like they move out and they come back. They move out, they come back, and they stay. Okay, leaving home for the first time, marriage, and the birth of a child. That's maturational, growing up. Situational. That means that something is happening in the situation that you're in right now. For example, you might go into work and they say, well, we're sorry, but we have to fire you because we're closing down. So an example of a situational crisis would be losing a job. Another example would be if somebody you love dies. And another example would be if you get a divorce. Y'all got that?
Maturation.
No. Maturational is when you get married.
Growing up, changes. I just put marriage.
It's supposed to be, maturational is supposed to be good things, like you're growing, good things are happening to you. Situational are bad things are happening to you. You get a divorce, you lose your job, somebody you love dies. Of course, some people might think that's good. I know you all don't think I'm a bad person, but when I was very young, my first husband, I used to tell him I wish he would die and I would dance on his grave. So,
I mean, some of the stories you've told, I'd say I'd give them at least till noon to get
an audience. Okay, adventitious. These are things that are beyond your control. It has nothing to do with you. It's the environment around you. For example, a natural disaster. There could be a tornado or a flood or an earthquake, something that you have no control over. You could have an accident. You could be in a car wreck, a boat wreck. You could be out hunting and somebody shoots you with a bow, an arrow. It's an accident. And then there are humans who are responsible for causing you to have an adventitious crisis. Like if someone were to rape you, or if they were to murder someone, or if you have to go to war. So natural disasters, yes, ma'am.
Wouldn't like rape and stuff, would that be situational?
No.
Okay.
Because it's unexpected.
It's beyond your control.
This is straight out of your book, so you guys can look at the page wherever that's at, and it will tell you exactly what's in it.
491.
Okay, maturational, leaving home for the first time, marriage, birth of a child. Situational, job loss, death of a loved one, divorce. Adventitious, natural disaster, accident, or another human. Y'all got that?
Mm-hmm.
Yes.
That's all I'm saying on this chapter. So now let's go to chapter 27. Anger, aggression, and violence.
For that chapter, that's all we need to study.
That's it.
Wow.
That's all you need to know for the test is what she just said. So we're moving on to the next chapter.
Take it all out of
Okay, is everybody on anger, aggression, and violence, chapter 27? I'm starting on slide 2. Clinical picture. Okay, so violence is associated with some psychiatric disorders. You have impulsive violence in somebody who has a psychosis, somebody with borderline personality disorder, somebody with PTSD, or somebody with intermittent explosive disorder. So when you guys are thinking about going to the psych unit, are you afraid that a patient is going to become violent and hurt you?
No.
So far, that has not happened, but it can happen. There is that possibility.
Don't worry, group 6, I got you.
I guarantee you.
And when you have anxiety, it can cause you to have negative feelings, and because you have those negative feelings, you'll have negative behaviors. So what you want to do if your patient is anxious and they're acting out, if you treat the anxiety first, that should take care of the behaviors. So when a person is angry, they're feeling frustrated, they feel like their needs are threatened, and they feel like they're being challenged. To me, I think frustration is the main thing. I mean, I know you get mad, but frustration bothers me more than anger does. And aggression. People who are aggressive, they are sometimes physically aggressive. They'll try to fight you. They're verbally aggressive. They'll talk really mean to you, hurt your feelings. Sometimes you have to be aggressive for your own good, to protect yourself. So aggression isn't always bad. But what you should never, ever do is use violence. One of my former students right now lost his license because he was working in a psych unit and a patient hit him and he hit the patient back and broke the patient's nose. So he lost his job, lost his license, getting sued, all that kind of stuff. So violence is not the answer. Okay, slide 3. I'm just going to tell you that violence can happen in any setting, and it does happen to nurses, and to other, like EMTs. There was an example in the book of an EMT that a patient stabbed him 7 times when he got in the ambulance with her. There was one patient was being attacked by a client, so another nurse tried to intervene and help her. He killed the one who tried to help. So it does happen. A nurse in an emergency room, a patient grabbed her stethoscope. You know how you guys wear them around your neck? He grabbed her stethoscope and choked her with it. When you guys are going to be working with somebody in a psychiatric unit, how should you dress?
Without anything hanging down,
Nothing they can grab.
Yeah.
Like nothing, no dangling earrings, no necklaces, bracelets. Yeah.
Kind of breakaway.
Okay, a breakaway. Shouldn't leave your hair down or leave your hair in a ponytail. Okay, on slide 4, all I'm saying here is that violence can be inherited. And people who have violent tendencies, their brain is different from regular people. There's actually a difference in their brain.
So we just need to know violence can be inherited.
Right.
Okay.
Okay, slide 5.
Cognitive factors.
Cognitive factors. I want your guys' input on this. I believe that when children play violent video games and they watch violent movies and violent cartoons, that makes them think it's okay to be violent. And they get desensitized to what's happening to the victim. Now, what do you guys think?
I'm on the fence. I think
It depends on.
Does anybody disagree? Okay, she disagrees. Let's hear what you're saying. Everybody listen, please.
You said that you think it does cause violence in children. I think it depends on who the child is as a person and what they're predisposed to genetically.
Okay.
Because I grew up playing video games and I'm not violent.
Okay, so she said she feels like it's who you are as a person and what you are like genetically.
But my brother is a violent person.
But her brother's violent. What were you going to say, Amanda?
Me?
Yeah.
I have 3 boys, and I think it's the environment. I mean, they all play the violent video games and all of that, but none of them are violent. They don't see that in our house. Mm-hmm. It's just in their video games. So I think it has a lot to do with how they're raised.
Yes.
I think that desensitizing is a good word. Just not to like make them love it, but desensitizing them to like death or hearing of a robbery or somebody getting shot because that's something they play. Like desensitizing, yes, I don't think it's going to affect who they are as a person.
I think I am a little desensitized to death on television because whenever I watch the news and I see somebody in Kyiv get shot and I know they're dead, I just say, oh, okay, they're dead. You know what I'm saying? Because we watch so many movies where the people die, and then they get up and they go on their merry way or whatever.
I mean, that one dude on 90 Days of Our Lives was dead for 45 times.
They just keep coming back. My little girl, Grace, is not my biological child. She's my great niece. I am a very calm person. I don't get angry. I don't lose my temper. I don't make a scene. I'm just very laid back. Oh my gosh. Grace loves drama. She screams. She yells. She slams the door. She throws whatever's in her hand.
Wait till she's 15.
No. Help for her right now. So,
good choice.
Even though she was raised in a household with the peace and all that kind of stuff, her mom, she inherited her mom's genes, and she acts exactly like her birth mother. So, I thought whenever I took Grace, because she was only 3 months old, I thought that she would be like me, because I'd be the one raising her, and she's not.
Now maybe she'll change though.
I hope.
Medication will help.
Okay, so violence is not a way to resolve conflicts, and violence usually has consequences when it is performed. If a person is a bully and they bully somebody else, that is a form of violence. If you tease somebody, kick them, hit them, spit on them, do anything that's meant to hurt somebody else, that is a form of violence. All right, slide 6.
Do we, for slide 5, do we need to know all of those, like,
All you need to know are the words that come out of my mouth.
Perfect. Just making sure.
Okay, slide 6. Now let me ask you this. Have you ever been around somebody and you could just tell by looking at them that they were getting mad and they were getting ready to explode?
Yeah.
How did you know?
Clenched fist.
They clenched their fists. What else? Their face gets red.
Clenched teeth.
They clench their teeth. Their body gets tense. You can just tell by looking at them to get ready to beat the crap out of somebody. Okay. Box 27.1 on page 504. I don't know why I've got that marked. What is it? Predictors of violence. Okay. Be aware of that. Now, when a person is being violent and you've just met them, like it's one of your patients, you should always go to the family, if they are there, and ask them if that is normal for that person. Because maybe it's somebody like me who's really laid back, but I've just had so much put on me that I can't take it anymore and I lash out. So see, it wouldn't be normal for me. On the other hand, if it was Grace, they'd say, yeah, that's normal. She does that all the time. So you need to know about your patients if it's normal or not. Also, you need to identify anything that triggers them. Like you can even ask them when they're calm, well, give me an example of something that really makes you angry or something that really makes you lose your temper. If you know their triggers and if you recognize the signs that they're getting mad, you can diffuse the situation before it happens. And that's what you want to do. Now, what about you? How do you react when somebody else is being mean and hateful and threatening and all that kind of stuff? How do you act?
They're being mean to me or somebody else.
I think me, I would take it, but if it's like my kids or something like that, then that's when mom and dad can try.
Okay, let's say that you have been in an abusive relationship and you're taking care of somebody now that's been in an abusive relationship. And all those feelings come back. How are you going to handle that?
You're going to say you probably want to feel your feelings out and your thoughts on the feelings.
Right. You need to always assess yourself before you go to assess your patient to make sure that you are under control. And also, whenever you are with your patients, you need to watch your facial expressions and your body language. I'm the world's worst with facial expressions because I go, ugh, and I roll my eyes, all that stuff. Alrighty, slide 7, outcomes identification planning. Table 27.1 on page 506. In order to plan your outcomes, you have to do a good assessment first. So you want to know the patient's history, if they have a history of violence, if they have any comorbid conditions that might add to it, like if they have ADHD, what kind of things have triggered them in the past, and what kind of coping skills they have. So table 27.1 on page 506 talks about your outcomes identification so you can make your plans, what you're going to do for your patient. But before you do that, you have to assess your patient. You have to know your patient's history, know if they have been violent in the past, if they have another condition that might contribute to their anger, like if they have ADHD, and what has triggered them in the past. And you also need to know what kind of coping skills they have. People who get angry and lose their temper usually don't have very good coping skills. Okay, slide 8. General interventions for somebody who's angry. Tell the patient you're concerned and you want to listen. So if somebody's going off on me, I'm going to stay real calm, and I'll say, I am so sorry that this is happening. I really want to be able to help you. Tell me what's going on with you. Let me listen, to what your problems are. You need to acknowledge the patient's needs, no matter what they are. If you think the patient's need is ridiculous, like they're throwing a fit because they don't have an ice cream cone, you still have to acknowledge that. Well, I understand that you really want that ice cream cone, and we can't do that right now, but maybe we can get that later. You need to clearly state your expectations for the patient. Like, I expect you to keep your hands to yourself, and I expect you to keep your voice calm. You're going to watch for early signs of distress. When you have tried everything else and everything else has failed, you might have to use restraints, chemical restraints, or put the patient in seclusion. That's always a last resort. And when you do that, try to be as nice as you can be while you're doing it. Don't lord it over them. Don't laugh at them. Ha ha, look at you. You thought you're a big man. Look at you now. You're all tied down. Yeah, you don't want to act like that. And even if you don't feel calm on the inside, if you're all torn up on the inside, try to act like you're calm on the outside. Whenever you leave the patient's room, then you can fall apart. When you are working with people, you need to give them their space. So, for example, when you guys go to the clinic, to the psych clinic, you want to stay at least 1 foot away from whoever you're talking to. And a rule of thumb is stay far enough away that they can't touch you and they can't kick you. That's for your protection. If you should happen to be in the patient's room, don't let the patient be between you and the door. When a patient has anger and it's escalating, it just keeps getting worse and worse, you want to make sure that you speak in a very calm voice, you speak slowly, and you use short sentences. You never want to yell at them. Have you heard the expression, throwing fuel on the fire? Mm-hmm. If you yell at them, it's just going to make them worse. You should ask open-ended questions. Why do you think that is?
Get them to talk.
That's a way for them to talk about their feelings. And at the end of your statement, do any of you guys ever say, okay, now, we're going to go to the store and I'll get you something if you're good, okay? Like how you say okay at the end? That's like telling them you have a choice. But you don't want them to have that choice. They're either good or they're bad, they get it or they don't. So you don't end your statement with okay. You want to try to find out what caused them to get angry in the first place. And you want to give them options. And let the patient make the choice. You could say to that patient, do you want to go to your room so you can calm down, or do you want to come with me to the activity room and we'll sit and work a puzzle? That may not be good examples, but I just want you to see the difference there. If you do take the client to another room, to another location, make sure the personnel can see you. Because you're taking an angry person into this room. And that angry person could kill you, right? You want to know that the staff is close to you and that they can see you so they can intervene if they need to. Slide 9. De-escalation techniques are on page 506. You guys need to read these. You want to protect the patient's dignity. You need to stay calm. You need to assess the patient in the situation. Identify stressors, intervene as early as you can. Always tell the truth. Don't tell the patient you're going to do something and then you don't do it. Don't argue with them. Give them options. Somebody tell me the difference between being assertive and being aggressive.
Well, just let them know you mean business, but no without threatening.
Okay. If you're assertive, it's like you can stand up for yourself. If you're aggressive, then you're trying to intimidate somebody else. Does that make sense?
Yeah.
Like if you overhear something and you say, I'm sorry, were you talking about me? Or you can say, were you talking about me? Which one's assertive and which one's aggressive?
Second one's aggressive.
I actually did that once. Oh my gosh, I'm so ashamed. I was coming out of a restaurant, and I was just like in my early 20s. And I heard a girl say something and laugh. And I said, are you talking about me? No. And I don't know what I would have done if she said yes. It just came out of my mouth. Okay, slide 10. Health teach and health promotion. You always want to be a role model. You can show the person the appropriate responses and the appropriate ways to react to anger by the way you respond and the way you react. And you're going to be an educator. You want to teach them appropriate ways to express their anger. Like instead of hitting the wall, hit a pillow. You don't do that, do you? You don't do that, do you? Okay.
I'm not an angry person.
Try to help them find self-soothing skills. Like maybe it might make them feel better if they pace or twiddle their thumbs or something like that. And again, you want to identify the triggers. Slide 11, teamwork and safety. All the team members have to do the exact same thing in the exact same way. If you make a rule, everybody needs to follow that rule. What happens if they don't?
There's a splitting where they ask you for it and you don't do it, then you can ask the other staff, they ask the other staff, and they get what they want.
It can cause splitting. It can cause division among the staff. It will keep the patient from getting the continuity of care that they should have. And we need to be proactive, not reactive. What do you think that means?
Do something.
Proactive means to try to take care of something before it happens. Reactive means something happens, and then how do you react to it? If you are working with someone who has an antisocial personality disorder, it's like these people don't have a soul, they don't have a conscience, and they really like to cause trouble. So they will do something and then blame it on somebody else. And sometimes they do that to make a commotion, like at the change of shift. They do it on purpose. Why do you think that is?
Create a distracting day.
Normally, it's because they have something planned that they want to do. Let's say that they have it in for somebody and they've got a toothbrush and they've made it into a shiv.
No, it's not focused because you're in the middle
Right.
of
And it's change of shift, and nurses are coming in, nurses are going out, nobody's really watching. They make this big commotion over here, and then over there, they're killing somebody.
Wow, I'm excited.
Okay. There are 6 basic considerations for ensuring safety. We've already talked about these a little bit, about not wearing necklaces and earrings and things like that. Make sure there's enough staff for backup. Always know the layout of the area where you are. Don't let the patient between you and the doorway. If you can tell that that patient is getting upset, you can give them some feedback. Like, you seem to be getting very upset. You know, let's talk about that. And avoid confrontation. Okay, slide 12 talks about seclusion and restraints. We have already talked about that in other lectures, right?
Yes.
So I'm not going to go over that again.
Okay, so we can X that out.
Take it out. But even if there was a question on it, you'd already know, because you've already had it. Slide 13. When a problem does happen at work, you need to have a debriefing. That's for your benefit. You want to look at the situation and think, what could we have done differently? How did everybody respond the way they were supposed to? How does the staff feel about that particular patient? You might need to give the staff more education. And if you do use restraints, were they applied correctly? Okay, on page 14, slide 14, where it says pharmacotherapy. I think there's only 2 drugs, and it is haloperidol and lorazepam. I think that's all you need to know. If it's not, I'll send you guys a message. Are we good? Yeah. Okay. Slide 15. When you're in the hospital, you kind of lose your freedom, don't you think? You have to stay in your bed most of the time. They tell you when you can eat. They tell you, you have to take this medicine. So when a person with a mental disorder is in the hospital, the first thing you want to do is an assessment in history. You want to find out, like I said before, if their anger is normal for them or if it's not. Then you want to find out their coping mechanisms. Because if they have bad coping skills, you could teach them good ones. You want to validate your patient. Let them know that you understand that they are in distress, and that you feel really bad about it, and you want to do anything you can to help them. Now, when you're really, really angry, do you want to talk to anybody? No. Do you think you could solve problems while you're really, really angry? No. Other than like breaking the dishes or kicking in the door or something like that? So anger affects your ability to communicate. So these people are going to have trouble communicating, and you want to try to get them to calm down. And if you let them know that you understand how they feel and what they're going through, if you name what they're feeling, like you seem really angry, or you seem really frustrated, or you seem really upset, then that might help them to calm down enough to talk to you. Box 27.4 on page 511, feelings that come before anger. Okay, slide 16. You have a patient that doesn't have good coping skills. So you need to try to understand and meet the patient's needs before they even ask for anything. Like bring your patient a cup of decaffeinated coffee and a magazine to look at. You just anticipate what their needs are. You need to use concrete communication. You know what it means to be concrete? There's no way to interpret it another way. So you're going to be very clear about what you say. For example, a patient asks you for a medication, and you say, I can't prescribe medications, but I will go to the advanced practice nurse and see if she will prescribe it for you. Okay? Then you carry through with that. You can use distraction to try to calm them down or to keep them from getting more upset, like video games, magazines, or books. If you keep your interactions with the patient predictable, then that gives them a sense of security, and they're not as likely to get angry then. Like if they know they're going to have breakfast at 7 o'clock, and they know they're going to have their meds at 8 o'clock, and they know they're going to have therapy at 9 o'clock, just try to keep things predictable as much as you can. You should always be respectful, teach one thing at a time, and give them choices. If you are with somebody who is being really out of control, like say you go in and they start cussing you out and calling you names and carrying on and you can't get them to calm down, it's okay to walk away. Just say, well, you're very angry right now, so I'm going to go ahead and leave, but I'll come back in about 20 minutes and check on you. It's okay to do that. If you are doing something that you can't leave the room, the book gave the example, like if you're changing a dressing and they're cussing you out and carrying on like that, what you can do is just stop talking to them, don't look them in the eye, finish what you're doing, and then leave. You don't want to argue with them, you don't want to be negative towards them. One time, I used to drive the church van at a church I went to, and there was this old lady, she's probably in her 80s, and she would get under my skin so bad. And we were standing in the vestibule, and I don't know what she said to me, but I started going off on her, and she was going off on me. And then all of a sudden I thought, what am I doing? Why am I standing here arguing with this old woman? I reacted. Okay. Another thing you can do is try to talk about something else. Like I said, keep a routine. Slide 17, patients with Alzheimer's or something like that. I think I've said it before. We need to go into their world. Don't expect them to come into yours. And that's that one. You guys good to go on for a little bit more?
Yeah.
Okay. Child, older adult, and intimate partner violence, chapter 28. You know how I say how much I like psych and I like teaching it and it's fun? It's not fun talking about this kind of stuff.
Yeah.
It's quite disturbing. Everybody ready? Mm-hmm. There are several types of abuse: physical, sexual, emotional, neglect, and economic. So physical abuse means that you inflict pain or bodily harm. Sexual abuse means that you either make sexual contact or sexual exposure without that person's consent. Emotional abuse is doing or saying things to make that person feel bad about themselves. Like, you are a rotten kid. You've always been rotten. You'll always be rotten. You are no good. You'll never be anything. That's emotional abuse. Neglect. There's different things a person can be neglected in. Neglect can be that you don't provide for them, like they don't have enough food or clothes or shelter. It could be that you don't take them to the doctor and the dentist. You can neglect your child emotionally. Just don't be there for your child. You can neglect to give them an education. Economic abuse would be when, say there's enough money to pay all the bills, but you take the money and you spend it, and then whoever is living there gets their electric and their gas and their water shut off. That would be economic abuse. Slide 3, family violence. We're talking about domestic violence. It is a crisis situation. Abuse or family violence can happen to anyone, even if you have good coping skills. The perpetrator is the one who does the harm. They're usually a violent person, and they think that their needs and their wants and their wishes are more important than anybody else's, and they're going to do what they have to have their needs met. The vulnerable person is the one who is hurt. Child abuse. There are acts of commission and acts of omission. If it is an act of commission, that means it is deliberate and intentional. That could be physical, emotional, or sexual abuse. Those are some examples. Deliberate and intentional, commission. Acts of omission. To omit something means you leave something out. So this falls under neglect. You can neglect them physically, emotionally, neglect their education. Maybe you don't protect them from harm. Maybe they don't have enough supervision at home. Or maybe you let them be exposed to too much violence. That's neglect. Everybody good? Slide 4, epidemiology and comorbidity. The youngest children are the most vulnerable. Usually children ages 1 through 4 are the ones who are most mistreated. Sexual abuse happens when they're young, and it seems like that it just keeps getting worse and worse and worse until they're about 17, when they're able to really take up for themselves and do something for themselves. Most of the time, who do you think is the one who hurts the child? The parents. They're usually, not always, but they're usually the culprits. If a person's being abused in one way, then they're probably being abused in another way. Like if they're being economically abused, you need to see if they're being physically abused as well. Does that make sense to you? When a person is being abused and you're doing an assessment on them, you might find that they're very anxious and depressed, and they might have suicidal ideation. The most common disorder caused by childhood trauma are, well, there's 2, major depressive disorder and PTSD. If you are raised in a violent family, then you are more likely to become a juvenile delinquent. You get in trouble with the law all the time. You're more likely to run away, commit violent crimes, become a prostitute. Adolescents that are abused usually have poor coping skills. Women who are abused sexually in their childhood usually develop some form of major psychiatric distress. Slide 5, risk factors. Being different. That just means if you are different physically, mentally, emotionally, or if you have a chronic illness, that makes you more susceptible to being hurt, to being abused. If you're taking care of a child that has cerebral palsy, let's say, and you just don't know how to care for them, you're at your wit's end, it might be easier for you to hurt them. If you are taking care of a person who maybe they're bedbound, you might be more likely, or someone might be more likely to abuse that person. If somebody has a chronic illness, like they have to be on a ventilator or they have to be on oxygen or something like that, they are more likely to be abused. Sometimes a child is abused because the child reminds the parent of somebody they don't like. For example, you look just like your dad, and I can't stand your dad, so I can't stand you. Have you guys ever seen that?
Yep.
Children from an unwanted pregnancy are more likely to be abused. And a child who has no bonding with their parents is more likely to be abused. Whenever Grace, before she was ever born, Kayla wanted to put her up for adoption because she didn't like the man she was with. And even after Grace was born, she said, oh, she's got toes just like him. And she never bonded with Grace. So, I took her. She was going to put her up for adoption anyway. So I took her. And I really feel like if Grace had stayed with her, that she could have been her. So you just don't know. Okay, slide 6, intimate partner violence. This is something that's caused by a current or former intimate partner. It could be your spouse, boyfriend, girlfriend, whoever you're dating at the time, whoever you're having sex with at the time. They could be part of the intimate partner violence. This includes physical violence, rape, stalking, and psychological aggression. You guys ever watch any of those movies where the woman had to leave her husband and then he stalks her and finds her wherever she is and she's met somebody else and she's finally happy and then he comes and tries to kill her and then the other guy kills the first guy, blah, blah, blah. Okay, slide 7. Intimate partner violence, epidemiology, and risk factors. Did you know that almost half of married couples, almost half of them, experience intimate partner violence? I did not know that. Have you ever known a man who thinks that a man is a man? And they want to dominate the woman? That type of person is more likely to hurt somebody else. A person who is jealous are more likely to hurt you. For example, they won't let you work anywhere except where they are working because they have to watch you all the time. They look at your odometer on your car to see how many miles are on it, so they know exactly how many miles you've driven that day. They take your phone and look at everything on your phone. They won't let you have friends. They want to just put you in, just you and them, and that's it. They separate you from your family. They separate you from your friends. You have to really beware of that. When they have alcohol use or substance abuse, they are much more likely to result in family violence. Alcohol use, substance abuse, more likely to result in family violence. Now, let's say that I'm the woman and my husband got drunk and he beat me up. Am I going to say probably, he shouldn't have got drunk and beat me up? Is that what women normally say? They don't. I might say, well, it was just the alcohol. He didn't really mean it. That's the kind of attitude that people get. Okay. If a woman becomes pregnant, that can trigger violence. Why do you think that is?
The partner may not want it.
The partner may not want to have a baby. Or the partner might be jealous, thinking you're going to pay more attention to the baby than you are to him. Do you know when women who are victims of abuse in an intimate partner relationship, when they are most at risk? When you're ready to leave. If you threaten to leave or you actually do leave, that is when you're most at risk. There is a cycle of violence. Oh, I'm sorry, slide 8. And this cycle of violence is one partner trying to control the other. So the first one is the tension building stage. There might be pushing, shoving, verbal abuse. And whoever is doing that, they rationalize their behavior. Well, if she had cleaned the house like I told her to, I wouldn't have had to push her down the steps. Okay. Whenever in this stage, when that tension is building, both people are going to try to diffuse it because they don't want it to blow up. But the way that they try to keep it from blowing up is what causes the problem. Maybe the man who is doing the abusing wants to calm down, so he goes out and gets drunk. Is that going to make the problem better? That's going to make it worse, right? Okay. Or maybe the woman who got pushed down the steps for not cleaning the house says, "Oh, it's my fault, honey. I should have cleaned the house." Does that help? No. All right, the second phase is the acute battering phase. And that's when the tension peaks. And it's usually triggered by something that happens. And sometimes the victim will even provoke the abuser into doing something just to get it over with. Have you guys, when you were a kid, you knew you were going to get a whipping? Have you ever, any of you guys get whippings when you were little? Oh, no. And then you think, well, I just want to go and get it over with. Well, it's the same thing in this person. They feel that tension so much, and they know they're going to get beat up. They know they're going to get beat up. They know they're going to get beat up. So I'll just go over and push him and make him beat me up, and then it's over with. I don't have to worry about it anymore. Do you understand what I'm saying? Yes. Okay. After that happens, they go on a honeymoon phase. In the honeymoon phase, the person who was doing the abusing, they will be all lovey-dovey and tell them how sorry they are. And they'll buy them flowers and give them gifts and promise never to do it again. And then that makes the victim feel like, oh, he really does love me. He said he's never going to do it to me again. He bought me roses. He must really love me. And then guess what happens? It starts all over again. It's just like a cycle, like a circle. It just keeps going. Slide 9, older adult abuse. You know, you think when a person gets old that they should, they've lived a full life and they should be able to relax and enjoy their life and have comfort. But a lot of old people do not have that at all because they're abused and they're misused. So if you don't provide this person's basic needs, and if you don't protect them from harm, that is abuse. Who do you think would be responsible for the abuse of an older person? Their caregiver? Their family? If they're in a nursing home or somewhere like that, the staff there? Financial abuse. Like say you're in a nursing home and this one nurse makes really good friends with you and she takes your checks and have you sign your name on it and then she writes a check out for however much she wants. Have you heard of stuff like that happening? Okay, risk factors. If they are in poor mental health or poor physical health, they're more likely to be abused. I had a patient in a nursing home. She was a mean old woman. She was just a mean old woman. And her son never came to see her. And when she wanted her cigarettes, I'd have to call him over and over and over to ask him to bring her cigarettes. And then I thought to myself, well, maybe if she's mean here, maybe she was mean when he was growing up. And she abused him, and that's why he didn't want to help her. So abusive parents are more likely to be abused by their children. The typical victim, the typical older victim of abuse is a female over the age of 75 who's white, lives with a relative, and has a physical or mental impairment. My mom is 82, and she's white, and she lives with me, and she has a physical and mental impairment, but I don't abuse her. But that would be the typical kind of person that would be abused. Slide 10. When you are assessing a person, let's say you're working in the ER or a doctor's office or somewhere like that, you're assessing a person, they might have some vague symptoms that you would want to notice, like they might have chronic pain or insomnia or hyperventilation or gynecological problems. Have you heard people say, well, it's all in your mind? Mm-hmm. It's really real. What you're feeling is really real, but your mind does cause it. So like this chronic pain could just be because of the turmoil that your mind is in. Maybe you can't sleep because of the turmoil that your mind is in. So when you assess them, you want to ask them questions about what's going on in their lives. Have you been sexually abused? Or are you being sexually abused? Have you experienced family violence? Is there drug use around you, or do you use drugs? Whenever you're doing this assessment, you want to have the person alone. Why do you think that is?
They could answer openly without fear of being assaulted later on.
Right. If there are abusers there with them, they're not going to let them answer questions. So whenever you're talking to them, you want to sit close to them. You don't have to sit in their lap. I don't mean that, but you want to sit near them. You want to take the time to establish trust and rapport. Why is that so important?
Well, you just gotta have a relationship where they talk.
Okay.
They don't trust anybody.
Okay.
They're probably scared. Don't want to open up about it.
Right.
They've been hiding it for so long.
So they're afraid. They're afraid to talk about it. They don't trust people. But you need to let them know that you care, that they are important to you, that everything they tell you, is going to be in their records, but it'll be confidential. And you want to be non-threatening and supportive when you're talking to them. And if you think that a parent might be abusing their child, you could ask the question, how do you discipline your children? Just that way it's like it's open question. It's not saying, do you beat your child with a stick? That wouldn't work. Also, when you're working with people, don't assume their sexual orientation. Like a woman might feel like she's a man might feel like she's a woman, etc., etc. Okay. What page is box 28.2 on?
521.
Okay, on page 521, key interviewing guidelines are listed. So you all need to read this and be aware of it. You need to let the person talk to you without interrupting them. Can you guys let somebody talk without interrupting them? Sometimes that is so hard for me to do, just to keep my mouth shut.
I really don't have any clue what that is.
You never keep your mouth shut, do you? You need to have questions that are open-ended, that they can give them a descriptive response, and ask them how they discipline their child. Like if a baby cries, what's a baby at risk for? We're going to be talking about that in just a minute. Okay. Slide 11. Assessing different types of abuse. So for physical abuse, your patient might have minor complaints like headaches, back trouble, and accidents. Like, I just fall down all the time. They could have overt signs, such as bruises, scars, burns, and wounds in various stages of healing. You can see box 28.3 on page 522 about that. If you're burned with a cigarette, what does it look like? Little round circle. You know, cars used to have cigarette lighters in them. Did you guys know that? And you just like push it in and it would get hot and it would pop out and then you could light your cigarette on the tip of it. But you also could burn somebody with it.
I was an awful child, and I was like 6 years old, and my sister was, I don't know, and I told her to touch the cigarette lighter, and
okay.
yeah, I got in a lot of, I don't know why I did it. I was just like, here, touch that, because I was the oldest, I was mean. I made her touch it.
Okay, you should expect abuse when the explanation doesn't match the injury. Like the side of their head is caved in, and they say, oh, she just fell out of the chair. And you think, there's no way this could happen from falling out of a chair. So the explanation doesn't match the injury. The patient might try to play it down, like, oh, it's not that bad, I've had worse. You know, don't worry about it, it's no big deal. They try to play down the seriousness of the injury. Or they can have really vague explanations, like, well, she was running through the house and she just happened to fall down the steps. You need to ask your questions directly, but in a non-threatening way. Like you could ask them, is someone hurting you? And when you ask them the question, you want to look at them to see if they have hesitation, to see if they'll make eye contact. Older children, like 6, 7, 8 years old, it's not uncommon for them to have bruises, right? Because they run and they play and they get hurt. But how about if it's a baby? Do babies normally have bruises? Okay, so if a baby has a bruise, then you need to investigate it. Shaken baby syndrome. Do you know what happens when they shake that baby? Its poor little brain just goes all over there inside their skull. It's the leading cause of death from physical abuse in children under 2. Yes, ma'am.
Why is it that shaken baby syndrome is so hard to be proven? Because I know that's kind of like a gray area for doctors nowadays. My friend, her son, had shaken baby syndrome. One doctor came in and said that's exactly what it was. He was bleeding from his ears, his nose, his eyes from his father. And he did not spend not one day in jail for it. And he has permanent conditions. He has tremors. He has no depth perception. When he walks, he doesn't walk properly because of it.
Yeah.
I mean, he's got all, like he's a teenager now. He's really a smart kid, but he's got a lot of physical disabilities from it. And his father did not spend that one day in jail. Because we had one lawyer come in and said that shaken baby syndrome was not a real thing, and it could not be proven. And the judge believed it.
So
not one day.
It's really hard, even though you have, like even though the patient presents with the typical symptoms of it, unless you physically see that patient or somebody do it to that baby, it's hard to prove in court.
That's what I was asking myself.
Yeah, you have. It's just because you have to physically see it, or it's a.
And he was home alone with
could have been an
dad,
accident.
Nobody was there to prove it. She was working and he was at home with the baby.
I mean, like you know he did it. Like you know he did it, but our system sucks unless you have physical proof other than what happened to the child, which could have been he could have fell off the couch, or you know what I mean. Like it's really hard to prove in court. I see it all the time.
I'm pretty sure she said that it never actually went to court because the lawyers kept pushing it back and pushing it back. So eventually they just stopped scheduling because it had been so long.
That is so sad.
So much.
Now, if they had done like bone scans and the baby had like previous breaks or fractures, they probably could have proven that it was abuse. But it's hard. Yeah, when it's the one event like that, it's really hard to prove in court unless they just confess. Like, yeah, I did it. I got frustrated. It sucks. I hate those cases.
Alrighty, so if you think the baby has shaken baby syndrome, you want to assess them for breathing problems, bulging fontanelles. Where are the fontanelles at? On their head. They would be bulging. They would have retinal hemorrhage. In other words, they'd be bleeding from their eyes. They could have a seizure. They could have vomiting. Or they could be in a coma. So these are the things you need to look for. Breathing problems, bulging fontanelles, retinal hemorrhage, seizures, vomiting, coma. Sexual abuse of children. Do you know what the most common symptom is for a child who's been sexually abused?
Sexualized behavior.
The most common sign or symptom is sexualized behavior. They might start talking about things that you have no idea how they know them because they're too young to know it. They might draw pictures that are sexually explicit. They might have sexual aggression. Or when they're playing with their toys, like if they're playing with two dolls, they will have it like the dolls are having sex or doing something like that. Those are things you can watch for. A child or a person who is an older adult who is emotionally abused is going to have low self-esteem. They're going to feel inadequate. They're going to have anxiety and be withdrawn and have poor impulse control. Clues that a child or an older adult are being neglected is they will be undernourished, they will be dirty, they won't have had dental care, and they won't have had medical care. Grace is really, really skinny. You know, she looks like a toothpick, and I'm fat. So I took her to this doctor for the first time. They looked at her, and they looked at me, and then they started doing these, well, let's weigh her, let's measure her, let's do this. And I knew what they were thinking. They think, that I wasn't feeding her. So I told them, I said, well, if you saw her mom, this is exactly how her mom is built. So, it's just a normal reaction, I think, to you want to help a person, and you want to make sure they're okay. So if you see this really skinny child, before you start making accusations, make sure that, there's something to accuse of.
I'm terrified someone's going to think I'm not feeding Freya enough because she's so petite.
Yeah.
She's so petite. But she literally has access to food all day. Always has snacks, 3 meals a day. And you can't make them eat.
Okay, I'm skipping assessment variables. I'm going to slide 13, assessment documentation. You want to write down verbatim what the victim says. You're not going to tell a story, make it into a narrative. You're going to write down verbatim what the patient says. You need to follow the procedure for collecting evidence. You need to follow it straight, exactly how it's supposed to be, because this is what they take to court. When a person has been hurt, bruises may not show up at first, so you might have to ask them to come back, say, in 2 or 3 days, so you can check their body again for bruising. Again, you want them to know that what goes on is confidential. And you should also tell them that when you're doing this examination and writing all this stuff down, that that's something that can be used in court against the person who hurt you. Have you guys heard of a body map? You all have body maps. Oh, no, you don't. I don't think ClinPrep has them. A body map was just like an outline of a generic outline of a body, and then you could just like draw a line, like bruise here, scar there, whatever. So you might have to do a body map too. Slide 14, self-assessment. You need to understand how you feel and why you feel that way, because if you feel very strongly about something, it could cloud your judgment. If you have a personal history of whatever's going on, that could cloud your judgment. And if you do have these problems, then you should talk to a professional about it. The only time in my life that I ever felt like I literally wanted to kill someone is when I thought a man had abused my child. And if I had seen him on the street, I think I would have run him down. That doesn't make it right. I'm not telling you guys to go out and do stuff like that. But I'm saying you have to assess yourself. Okay. So slide 15, outcomes identification and planning. Most of the time the people go in and they get treated in the ER or wherever, but the main interventions are going to take place in the community. And remember that patient safety always comes first, and you always want to include the patients when you're making plans. Slide 16 talks about a safety plan. This is a plan for a rapid escape from abuse. And there's a picture in your box. In your box. I'm sorry, I see words and I say them. There's a picture in your book of it. Box 28.5 on page 527 you should look at. So you need to teach the patient the signs, that the tension is escalating or that the violence is going to get worse. And then they need to have a code word, like they can use with their child. What? Okay. So that the child will know this means get up and go. Like if your code word was bananas, you'd say, Grace, did you eat any bananas today? And then Grace would know, oh, we need to leave. And so she would get up and go to her room or whatever. Okay. You want to leave before the violence occurs, if you possibly can. On your plan, you should have a destination written down. You should have a means of transportation. You should have your bag already packed and ready to go. You should have money. You should have a cell phone that's fully charged. But you want to keep these things hidden because you don't want that violent partner to find them. Say that you're working in the ER and this person has come in because their partner has beat them up and they decide that they want to leave, they don't want to be admitted. The most important intervention you can do for that person is to give them a list of shelters and safety houses in their area. And you can give them the phone numbers. You can also give them phone numbers for hotlines that they can call, or maybe a YWCA if they need to be sheltered. Okay, that's it for that one. Can you guys bear with me just a little bit longer? You want to take like a 10-minute break? Yes? Okay, take a 10-minute break. It's 20 after. I'm going to start on the dot at 1:30. Chapter 29, Sexual Assault. Slide 3. There is attempted rape and completed rape. if you are penetrated by any object, that it is a completed rape. Any object anywhere in your body. Whether it is a man's penis or a trophy or whatever, if they put anything in your mouth, in your vagina, or in your rectum, it's completed rape. Attempted rape means they try to do it, but they don't succeed. Do you guys believe, slide 4. Do you all believe that a married woman or a married man can be raped by their partner? Yes. There is such a thing. Whenever we're talking about sexual violence and partners and all that, it's not just a man and a woman. It could be a woman and a woman or a man and a man. They're all just as liable to experience this. Date rape. You guys know what that is? Mm-hmm. Somebody takes you out on a date and they spike your drink or whatever, and then they rape you. Okay. For some reason, I don't have any notes on these pages, so I'm just winging it. So this will probably not take very long. The drugs associated with date rape are on page 5. I know there's a box or a table.
Table 29.1 on 536.
536, table 29.1. So just know the drug, and you can know the effect, and you could know like signs of overdose or toxicity, something like that. Okay, laws and sexual assault. I don't know. Okay, on slide 7, where it's talking about specialized sexual assault services. Have you guys heard of a SANE nurse?
Yes.
That is SANE. This is a nurse who is specifically trained to perform the assessment on a person who has been raped. And this nurse is specifically trained on what evidence to collect and how to collect it so that it will stand up in court. A person who is raped, on slide 8, they're going to have severe and long-lasting emotional trauma. A rape isn't something like you break your leg and you get over it. A rape is not like that. A rape is always an act of violence. You guys hear me? Mm-hmm. Rape is always an act of violence. It is not an act of passion. People who have been raped might become hyper alert. They are just, they hear every sound, they see every person, and they're just wondering who's going to hurt them next. They may experience depersonalization, where like their body just doesn't feel real to them. And if a person is raped by a family member, if it's incest, they're going to have a really poor self-image. I can't believe I didn't make notes on this stuff. What's wrong with me? Okay, slide 9, application of the nursing process. You want to assess their level of anxiety, because if they're in a panic level, you're not going to be able to do anything with them, right? So if they're panicky or if they're in a real severe anxiety state, you need to help them to calm down before you can do anything with them. You need to know what kind of coping mechanisms they have. So if they don't have good coping mechanisms, you can teach them good ones. You need to know about their support system. Because again, remember I said even if it's just one person, somebody to talk to, everybody needs that. You can talk to them about the signs and symptoms of emotional trauma, like the depression and anxiety, things like that. And of course, you want to do your self-assessment. This is chapter
Page
20.
538. You're on.
138?
538.
Oh, 538. Okay, that table 29.1 on page 536, you need to know the name of the drug, the effect on the victim, and the overdose symptoms and treatment. And I just talked about the SANE nurse. That's on page 537.
I'm confused.
What are you confused about? I'm reviewing. So sorry. I'm catching myself up.
Okay, so 536 is the name, the effect, the overdose, and all that stuff.
Uh-huh. All right, let's go to 538. We've already talked about the level of anxiety, coping mechanisms, available support systems, emotional trauma. There are 5 steps in the best practice guideline. You want to perform a head-to-toe assessment, and you're looking for signs of injury. You want to do a detailed genitalia assessment, looking for signs of injury. You want to collect the evidence in the correct way. And you want to document what you find. You're going to document it in writing, and you're also going to take pictures or draw pictures. So writing it in pictures. And then you're going to go over the treatment, the discharge planning, and the follow-up care. For example, when a woman is raped, they always give them a pill so that if she was pregnant, or keep her from getting pregnant. And they will treat for sexually, what do they call those diseases? STDs. Like chlamydia, that kind of thing. This rape trauma syndrome, I want you guys to read about that. It's on page 539 under nursing diagnosis. Let's look at table 29.3, the myth versus facts. Have you ever heard it said that if a woman didn't dress so provocatively, she wouldn't have been raped? Mm-hmm. What do you think about that? She's not asking to be raped. The person who does the raping is the one with the problem, right? When a man is raped, he is more likely to have physical injury than a female. I just thought of that. How about if I record this lecture?
That sounds wonderful.
Yeah. Because I don't know what I'm doing. My true age has caught up with me. Okay, so I'll let you guys go.
Thank you.
Test on Tuesday, right?